Good morning, everyone. I think we'll be ready to start. And it's my great pleasure. My name is Linda-Gail Becker, the president of the International AIDS Society. I'm joined. Oh, I hope that doesn't augur in any direction. Thanks, guys. There you go. We'll put that back for the photo opportunity. Great. Sorry about that. Thank you. No one was hurt, so that's important. Great. Linda-Gail Becker and my co-chair for the IS 2017 meeting, Jean-François, we have instituted a new concept at this conference. It's always good to have something novel and new, and that is the co-chair's choice. So you'll see this is truly a potpourri of abstracts that we have chosen simply because we think they really demonstrate the depth and the breadth of the science that is showcased at this conference, but also we think they're going to have particular interest to the field, either because of issues of access or issues of success, or indeed because they are truly new innovations that we think the field has been waiting a long time for. So I'll kick off with our first abstract, and without further ado, and it's the usual strategy. Because they're so different, I think what we'll do is allow the abstract presenter to present their data. We'll have a few minutes to invite some clarification questions, then move to the next. If there's time at the end, we'll open the panel at large for more questions. So our first speaker is actually going to be a duet, which I know does not appear in the program at the moment, but it'll be a duet from Sheila Malloy, St. George's University of London, and Cecilia Kanyama from the UNC project in Kisumu Central Hospital, Lilongwe, Malawi. And this abstract is a randomized controlled trial for the treatment of HIV-associated cryptococcal meningitis in Africa, oral fluconazole plus flucytosine, or 1 week of amphotericin-based therapy versus 2 weeks of amphotericin-based therapy. It's known as the ACTA trial. Sheila.
Good morning. My name is Cecilia Kanyama, and this is Sheila Malloy, and together we'll be presenting results from the ACTA trial, which is the largest trial on cryptococcal meningitis to date. This is on behalf of the ACTA trial team with Chief Investigator Tom Harrison. I'll start by giving some background information to cryptococcal meningitis, including issues with current treatment and results from phase 2 data, and then present the trial design and end with trial results. Cryptococcal meningitis is a leading cause of death in HIV-infected patients in Africa. It accounts for 15% of all HIV deaths, resulting in over 100,000 deaths per year. Mortality at 3 months is estimated to be as high as 70%. The IDSA and WHO Rapid Advice Guidelines recommend 2 weeks amphotericin B plus flucytosine as gold standard treatment. However, the current gold standard treatment is not feasible or safely sustainable in many resource-limited settings in Africa. Flucytosine is not registered or available across many African countries, and amphotericin B is not available in many centers. And where it is available, it is a very expensive drug, requiring hospital admission with IV administration, and has notable side effects, including renal and hematological toxicities. Thus, many centers rely on fluconazole monotherapy, despite the fact that fluconazole is significantly less rapidly active than amphotericin B, and has been consistently associated with greater than 50% mortality at 10 weeks and over 75% at 1 year. Therefore, the aim of the ACTA trial was to build on phase 2 studies and to define regimens that will be more appropriate in the African setting and also be accepted than the gold standard 2 weeks amphotericin and more effective than fluconazole. In addition, we aim to determine whether flucytosine or fluconazole is superior as an adjunct treatment to amphotericin B. Preliminary data in animal models demonstrate that just 3 days of amphotericin B dosing gives the same 2-week fungal counts reduction as 14 days of daily dosing. And we also see clinical trials in South Africa, Uganda, and Malawi, where just giving 5 to 7 days of amphotericin B is well tolerated and associated with lower mortality than with fluconazole alone. And again, it shows prolonged antifungal effect with no decrease in clearance rate in the second week. First 2 studies have shown that there's a benefit of adding flucytosine to fluconazole. In Malawi, a phase 2 randomized clinical trial showed the rate of clearance of infection was greater for oral combination compared to fluconazole alone, and was comparable to clearance seen with amphotericin B-based therapy. And you can see that there's also evidence for a difference in 2-week mortality with fewer deaths in the combination arm compared to fluconazole alone. So this preliminary data leads us to the ACTO trial, which is an open-label phase 3 randomized controlled non-inferiority trial to compare treatments for cryptococcal meningitis. This study was funded by MRIC in the UK and ANRS, and sponsored by St. George's University of London. In this trial, we had 3 treatment strategies. The strategy 1 was an oral combination of high-dose fluconazole and flucytosine given for 2 weeks. The second was an induction therapy of amphotericin B based with either high-dose fluconazole or flucytosine for 1 week. And the third, which is the control arm, was amphotericin B based with either high-dose fluconazole or flucytosine, but given for 2 weeks. You can see from the flow chart here that eligible patients were consented and randomized to one of the 5 treatment arms. After 2 weeks, all participants received fluconazole 800 milligrams until ART was started or initiated at 4 weeks, and patients were followed up to 10 weeks for outcome. I'll now let Sheila present to us results of the trial. Thank you.
Thanks, Cecilia. So patients were recruited between January 2013 and December 2016 at 9 sites in 4 countries across Africa. HIV seropositive adults where the first episode of cryptococcal meningitis were included, and we had very few exclusion criteria. Due to the need for rapid treatment, patients that were enrolled that had baseline bloods coming back with abnormal blood results or abnormal renal or liver function were excluded late, so post-randomization. The primary outcome when comparing oral and 1-week amphotericin B with 2 weeks of amphotericin B-based regimens was all-cause mortality at 2 weeks. We had a number of secondary outcomes, particularly 10-week mortality. And for the adjunct treatments, comparing fluconazole with flucytosine as adjunct treatment with amphotericin B, time to all-cause mortality at 10 weeks was the main outcome. Our target recruitment was 680 patients. This gave us 90% power with a non-inferiority margin of 10%. So in total, 1,243 patients were screened, 522 were excluded, and 721 were enrolled and randomized. 678 were included in our intention to treat analysis, with those excluded meeting the predefined late exclusion criteria. 662 participants were included in the per-protocol population, and just 4 patients were lost to follow-up, and only 1 patient within our primary endpoint of 2 weeks. We can see here that the baseline characteristics were balanced across the groups, especially for poor prognostic markers such as Glasgow Coma score, CSF fungal count, and CD4 count. Proportion of deaths was similar across the arms, so 18% in the oral regimen, 22% in the 1 week of amphotericin B-based regimen, and 21% in 2 weeks of amphotericin B. When we compare oral with 2 weeks of amphotericin B and 1 week compared to 2 weeks of amphotericin B, we can see that the upper 95% confidence interval is well within our predefined non-inferiority margin of 10%. Mortality at 10 weeks was 35% in the oral, 36% in the 1 week of amphotericin B, and 40% in the 2 week of amphotericin B-based regimens. And again, the upper 95% confidence intervals were well within our predefined margin. We can see the results again here displayed graphically, and also for our per protocol population. And these results were consistent for our adjusted and sensitivity analyses. If we look at a cumulative incidence of all-cause mortality, here in the bottom is the blue line, is the oral regimen of fluconazole and flucytosine. In red in the middle is 1 week of amphotericin B, and on top in green is 2 weeks of amphotericin B. And there was no difference between oral and 2 weeks and 1 week and 2 week based amphotericin B regimens, both at 2 weeks and 10 weeks. Looking at the rate of fungal clearance, when we compare the oral arm with the 2 weeks of amphotericin B based therapy, the oral arm had a slower rate of clearance, and this was significant at the 0.1% level. Comparing 1 week of amphotericin B to 2 weeks of amphotericin B, there was no difference in the rate of clearance. In terms of safety, there was a high frequency of adverse events in each of the 3 regimens, and this is reflective of the immunosuppression in this patient population. As expected, anemia was higher in the 2 week amphotericin B-based regimen, and this is in terms of both number of grade 3 and grade 4 adverse events, and also in terms of the change in hemoglobin to day 14. There was also a higher percentage of patients that required transfusions in the 2 weeks of amphotericin B-based regimen. Very few patients had grade 4 neutropenia or hypokalemia or elevations in ALT. And again, as expected, rises in serum creatinine were highest in the 2 weeks amphotericin B-based regimen. If we now look at the adjunct treatment, so comparing fluconazole to flucytosine as an adjunct with amphotericin B, the red line on the bottom here is flucytosine, and the blue on top is fluconazole. The 10-week mortality for fluconazole was 45%, compared to just 31% in the flucytosine arm. And this difference was significant for 10-week outcome. In terms of rate of clearance, flucytosine was also superior to fluconazole. And the difference between flucytosine and fluconazole was driven by large differences in the 1 week arm. So if we now look at cumulative incidence of all-cause mortality broken down into 5 arms, on the bottom we have amphotericin B plus flucytosine for 1 week in green. In blue is the oral regimen. Pink is amphotericin B and flucytosine for 2 weeks. Brown is amphotericin B and flucytosine for 1 week. Brown is amphotericin B and fluconazole for 2 weeks. And on top in red is amphotericin B and fluconazole for 1 week. 10-week mortality for 1 week of amphotericin B plus flucytosine was remarkably low at just 24%. And when we compare this to the current gold standard of 2 weeks amphotericin B and flucytosine, it was superior with a hazard ratio of 0.56. If we compare all arms to this best performing regimen of 1 week of amphotericin B and flucytosine, we can see that 1 week of amphotericin B and flucytosine was superior to all other arms, with the possible exception of the oral regimen, or the oral arm, where it was just borderline significance. So in summary, we've demonstrated that short course 1 week of amphotericin B-based therapy and oral combination of high-dose fluconazole and flucytosine are non-inferior to 2 weeks of amphotericin B-based therapy. Notably, flucytosine was involved in all best performing arms, and as adjunct therapy with amphotericin B led to lower mortality compared to fluconazole. 1 week of amphotericin B and flucytosine was associated with better survival compared to all other arms, and these results may reflect, at least in part, the balance between the rate of clearance of infection and tolerability. In terms of a policy impact, reduction in cryptococcal meningitis mortality from the 70% seen with fluconazole monotherapy currently to the 25 to 35% as seen in the flucytosine-containing regimens in this trial could save tens of thousands of lives every year. And we advocate that centres in Africa should use 1 week of amphotericin B plus flucytosine as first-line induction therapy for patients with cryptococcal meningitis. If amphotericin B is not available, or it's not possible to safely administer, then the oral combination of high-dose fluconazole and flucytosine provides an effective and sustainable alternative. And urgent efforts are now required to ensure that flucytosine is made widely available for the treatment of cryptococcosis. So the conduct of this trial was a huge collaborative effort, and we'd like to thank a really fantastic trial team, and also our funders and sponsors and oversight committees, and all the patients and guardians involved in the trial. Thank you.
Great. Very nice. We have a couple of minutes for questions. If you could come to the microphone and just state where you're from. So a question. Thank you.
It's David Denning from Manchester and Gaffey. It's a fantastic piece of work, all of you. Well done. It's really quite exceptional. So you haven't got amphotericin in your hospital. You've just got fluconazole at the moment. Hopefully somebody will license flucytosine and make it available. The government will buy it and make it available. Do you think the duration of therapy of the dual, how long do you think the duration of therapy for dual should be? When would you revert from your high-dose fluconazole and flucytosine down to sort of standard dose? Do you think it's still just a 2-week course, or do you think actually there's any benefit for longer for the combination?
Sure. So obviously in this trial, the 2-week oral combination was what was tested, and it was shown to be non-inferior. So it does seem to be a good alternative regimen. Of course, you would have to conduct further studies if you thought a longer-term treatment was.
So what proportion of patients were still culture positive at 2 weeks in that combination? In other words, you know, because if you're still culture positive, you might assume that fluconazole will carry on, but it might not. And maybe there's a way of stratifying the patients at 2 weeks to decide how long to give combination for.
True, yeah, that's a good question. So we are going to look further into patients' severity of illness of patients, and that's probably something we look at then as well in terms of clearance at 2 weeks. Thank you.
Wafa?
Hi, good morning. Thank you. Terrific study. I guess my sense is the mortality was quite high, even in the best arm, and it raises the issue of prevention of cryptococcal meningitis, since it's such a deadly disease once it occurs. And I know that the reality study results were just published this week, I believe. So I'm just kind of wondering if you're thinking of, is there any other way that we can try to decrease the mortality further?
Sure, I think that's a really good point. So I think screening is obviously very important, and we need that in terms of prevention. And perhaps instead of treating with fluconazole when patients are positive at screening before they have meningitis, perhaps the oral combination is a good alternative then, and we are trying to get funding at the moment to look at that, to see if we can have a better treatment before patients get meningitis.
Very much indeed to Sheila and to Cecilia, and perhaps I'll just also say that in conversation with Tom Harrison, Unitaid is really looking at trying to make this drug available, so a multi-pronged approach. Thank you so much to both of you. I'll hand over to you.
So the next speaker is Rebecca Zasch, and the topo is on Dolutegravir, tenofovir FTC, started as pregnancy that's safe as equivalent tenofovir FTC in nationwide birth outcome surveillance in Botswana. Very, very nice subject, very important subject with the Dolutegravir. Yeah.
Thank you. On behalf of my co-authors, I'm very happy to be here today. We have no disclosures. So many countries are moving towards a dolutegravir-based antiretroviral therapy as first line for HIV-infected adults. There's many reasons for this. It's efficacious, it's taken just once daily, there's a high genetic barrier to resistance, it's well tolerated and generally has few drug-drug interactions. But the rollout of dolutegravir is hampered partly because of the inability to harmonize ART guidelines for both adults and pregnant women. Currently, the WHO and US guidelines do not recommend dolutegravir in pregnancy because we're really lacking safety data on dolutegravir use in pregnant women. And this is one of the biggest challenges for many high-burden countries throughout the world. Botswana recently became the first national program to use dolutegravir in pregnancy. Between 2012 and April 2016, Botswana used efavirenz TDF-FTC for all adults with CD4 counts less than 350, and all pregnant women regardless of CD4 count. But in May 2016, there was a nationwide rollout of dolutegravir TDF-FTC as first line for all naive adults and all pregnant women, regardless of CD4 count. And this was using a test and treat strategy. In Botswana, since 2014, we've been performing a birth surveillance study to evaluate the safety of ART regimens in pregnancy. This study is called SAPAMO. It's an R01 funded by NICHD, and Roger Shapiro is the PI. And this study was conceived with two primary aims. First, to compare birth outcomes by ART regimens taken from conception. That was a 2-year analysis. And to evaluate the risk of neural tube defects in first trimester efavirenz exposure, and that was the planned 4-year analysis. In the SAPAMO study, we abstract data from all consecutive births greater or equal to 24 weeks gestational age at 8 wards in Botswana. We consent mothers at these sites to take photos of infant congenital abnormalities. And in the first 2 years of our surveillance study, from August 2014 to 2016, about 95% of deliveries in Botswana occur in healthcare facilities, and we captured data on 47,027, 99.8% of all births at our study sites. And this represents about 45% of all births in the country. Among these women, 99% had a known HIV status, 25% were HIV infected, and 91% were on antiretroviral therapy prior to delivery. 94% of those women had a known and specified ART regimen, and only 0.3% switched or terminated their ART during pregnancy. Before the dolutegravir rollout, we completed our 2-year analysis of SAPAMO, where we found that efavirenz TDF-FTC, the first-line WHO recommended regimen, was safer than older ART regimens in pregnancy. What you can see here in the lighter bars is the prevalence of any adverse birth outcome, and in the darker bars, any severe adverse birth outcome among HIV-uninfected women and women on 5 different ART regimens from conception. And we found quite large absolute differences between any adverse birth outcome and any severe adverse birth outcome, with women on efavirenz TDF-FTC having 6 to 12% lower risk of any adverse birth outcome and 6 to 11% lower risk of any severe birth outcome. And all of these were statistically significant differences. So taking advantage of the shift in Botswana guidelines, we did a dolutegravir analysis within the SAPAMO study with the primary aim to compare the risk of adverse birth outcomes among women initiating dolutegravir TDF-FTC compared with women initiating efavirenz TDF-FTC during pregnancy. We included 4,593 women who started a efavirenz-based regimen in pregnancy and delivered between August 2014 and August 2016, and 845 women who initiated dolutegravir-based regimen and delivered between November 2016 and April 2017. In terms of exposures, we defined this as documentation of one of these 2 regimens started at least 4 weeks after conception and not switched or terminated during pregnancy. And we looked at 9 different outcomes. We looked at stillbirth, neonatal death, preterm birth, very preterm birth, small for gestational age, very small for gestational age, and 2 combined endpoints, any adverse birth outcome, which was a stillbirth, a preterm birth, SGA, or neonatal death, any severe birth outcome, which was a stillbirth, a very preterm delivery, very SGA, or neonatal death. And we also looked at congenital abnormalities identified on the newborn surface exam and photos reviewed by Dr. Lou Holmes, an expert in Boston. For our statistical analysis, we compared the prevalence of individual and combined adverse birth outcomes by ART regimen using a log binomial regression among singleton births. We adjusted for maternal age, educational attainment, and gravida, a priori based on findings that these were significant confounders in our prior birth surveillance studies in Botswana. The maternal demographics were quite similar between the dolutegravir and the efavirenz groups, similar ages, similar socioeconomics. They delivered at similar sites with similar obstetric history, and they presented for their antenatal care at the same time. There were a few differences in baseline HIV characteristics between these two groups, which has to do with the transition to test and treat with the dolutegravir rollout. Primarily, women on dolutegravir-based regimens had a shorter number of days between their first antenatal clinic visit and the start of their antiretroviral therapy, 11 versus 23 days in the efavirenz group. They also had fewer CD4 counts reported in pregnancy, only 17%, compared with 45% of women on efavirenz. However, CD4 counts were similar and quite high, both above 400. So these are our main results. Here you can see any adverse birth outcome was 34% among women on dolutegravir, compared with 35% among women on efavirenz, and severe birth outcomes was 11% for both groups. In adjusted analysis, the risk was 1.0 for both of these outcomes. The results for preterm birth were very similar. 18% had a preterm birth in dolutegravir group compared to 19% in the efavirenz group, and 4% in each group had a very preterm birth. And again, there was no difference in statistical and adjusted analyses. Similar again for SGA and very SGA. 19% SGA in both ART groups, and 6% very SGA in the dolutegravir, compared with 7% in the efavirenz, non-significant in adjusted analyses. For stillbirth, it was 2.1% among dolutegravir and 2.3% among women on efavirenz. Again, not a statistically significant difference. And neonatal death, both 1.3% for both groups and non-significant. In terms of congenital abnormalities, these are very preliminary data as we didn't have very many first trimester ART exposures, 116 in dolutegravir and 396 in efavirenz. But among this group, we've only found one major congenital abnormality, which was skeletal dysplasia among an efavirenz exposed infant. So in conclusion, I think the risk of adverse birth outcomes are quite similar among HIV-infected women who initiate dolutegravir TDF-FTC compared with efavirenz TDF-FTC in pregnancy. I think these preliminary data are very reassuring, but not the entire story. I think we still have to go further to evaluate birth outcomes with dolutegravir exposure from conception. We have to have larger numbers of first trimester exposures to look further at congenital abnormalities. We need to look in combination with other backbones, including abacavir 3TC co-formulations, and also there could be differences in maternal viral load at delivery, or possibly MTCT. And just need to thank many, many people for having this happen, including NACHD, and in particular the Ministry of Health in Botswana, who have been our partners, the midwives, doctors, and hospital administrators, and the Botswana-Harvard Partnership, and then this amazing group of research assistants who make this study possible. Thanks.
Thank you very much. We have time for 2 questions. Yeah.
I'm happy to ask a sort of policy type thing. I mean, obviously, the implication is then that you want to have, are we ready to change guidelines and see Dolly in pregnancy?
I mean, I think that's fortunately not a question I have to answer. But you know, my personal view is with this data, although it's relatively small, when you look back at these really huge differences we found in outcomes on the other regimens, and then these are just so incredibly similar. And we're now up to about 1,500 and have the same results. So, you know, I believe these data. I think dolutegravir is going to be safe in pregnancy. As safe as efavirenz, I should say.
Yeah.
Polyclonal HIV based. In the absence of any better questions, when are we going to see a similar data set for women who've conceived on dolutegravir?
So we think in 2 years' time. We have only 33 this year, but it grows by about 9% per year. So 2 to 3 years.
Oh, actually, that's what I was going to comment. I think we need to see that 2 to 3 years to come. And I'm from Botswana, from the Ministry of Health. So thank you for demonstrating that we are not wrong in actually taking that decision to go to dolutegravir. Thanks.
Yeah. One additional question. Do you have the possibility to have a long-term follow-up for infants?
We don't have that currently. We would love to do it. It obviously takes a lot more money, and it's more challenging, but we would really be interested in doing that.
Thank you.
Good. Well, thank you very much
Thank you very
indeed. So our third abstract today is from Martin Markowitz at the Erin Diamond AIDS Research Center, Rockefeller University. And this is looking at a novel agent, weekly oral MK8591, protects male rhesus macaques against repeated low-dose intrarectal challenge with SHIV C109P3. Marty.
Bonjour, merci, and thank you to the co-chairs for selecting our abstract for presentation. We're very pleased to present these data. Here are my disclosures. As you heard elegantly presented this morning by Sheena McCormick, PrEP prophylaxis of HIV infection with antiretroviral agents is a safe and effective addition to the HIV prevention toolbox. As you heard, additionally, efficacy is variable and has been intimately linked to adherence. Therefore, the identification of clinically relevant compounds that protect against HIV infection with the potential for alternatives to daily oral dosing has become a research priority. MK8591, aka EFDA, is a novel compound of interest. This compound is a potent and long-acting nucleoside reverse transcriptase translocation inhibitor, otherwise known as an NRTTI. It's a new term for everyone. It has multiple mechanisms of action. It is associated with immediate chain termination by inhibition of primer translocation. And it also causes delayed chain termination, which prevents nucleotide excision from occurring. Importantly, for prevention, the active drug, MK8591 triphosphate, concentrates in both rectal and cervical tissue. These are results of a single-dose study in HIV-infected humans. On the x-axis days, on the y-axis change in viral load. And you can see in these patients a single 10 milligram dose effected approximately a 1.6 to 7 change in viral load. And that was associated with a trough level of about 1 picomole per 10 to the 6 cells of active drug at 1 week. I call your attention to a late breaker poster that will be presented tomorrow by Matthews et al. Describing further data on the antiretroviral activity of this compound. This compound has also been studied in SIV-infected macaques, and these data formed the foundation for the challenge experiment I will discuss today. These animals received 2 weekly doses of varying doses of MK8591 based on weight, and you can see that doses of 3.9, 13, and 18.2 mg per kg gave a very nice, robust antiviral response. And again, an intracellular level of about 1 picomole per 10 to the 6 cells was associated with a 90% maximal response. Using these data, we performed the following experiment. Repeated low-dose intrarectal challenges to evaluate MK8591 as PrEP in 16 Indian rhesus macaques. 8 animals were treated and 8 animals served as controls. The animals were treated with 10% tween at 5 mils per kilogram with or without MK8591, 3.9 mg per kg by oral gavage up to 14 time points, and that's shown in blue. At baseline and day 6 and weekly thereafter, blood was drawn for virology, immunology, and pharmacokinetics. Starting at day 6 and weekly thereafter, animals were challenged with 50 TCID50 of SHIV intrarectally, up to 12 challenges. And note that after the 14 treatments by oral gavage, there was a substantial washout phase. For this experiment, we used a SHIV 109CP3. This is a subtype C pathogenic R5 SHIV. It's constructed from a clade C HIV ALM clone that's a transmitter founder virus that was constructed by Cecilia Chang-Meyer at the Aaron Diamond. The virus was cloned into SIV and serially passaged in rhesus macaques. As shown in panel 1, when rhesus macaques were infected with 5,000 TCID50 of virus intrarectally, the virus established high peak viremia. In panel 2, this was associated with substantial CD4 depletion in the periphery. And in panel 3, you can see that there's substantial CD4 depletion in the lamina propria, consistent with HIV, SIV, and SHIV infection. SHIV RNA in plasma was quantified by RT-PCR with a limit of detection of 40 copies. Systemic infection was defined as 2 consecutive positive signals, and in this experiment, the eclipse phase was 1 week. Proviral DNA was also determined, and that was a qualitative assay. Virus-specific antibody levels were measured, and PK levels of prodrug and active drug were also measured in plasma and PBMC. These are the results of the untreated animals. 6 out of the 8 animals were infected after 1 challenge. An additional animal became infected after 2 challenges, and the 8th animal was infected after 4 challenges, translating into a median of 1 challenge and a mean of 2. And as I like to say, this is the money slide. The treated animals shown in red and the untreated animals shown in black. And you can see that in red, the treated animals during the challenges and during the washout phase remain uninfected, and the control animals, as I showed you earlier, all became infected rather rapidly. This translates into a 41.5-fold lower risk of infection, and you see the 95% confidence interval, and this is a highly statistically significant finding. Proviral DNA was not detected in the PBMCs in any of the treated animals. It was detected in all the in the PBMCs of all the placebo animals simultaneous to the time that we detected plasma viremia. Virus-specific antibody responses were not detected in any of the treated animals and were detectable 1 to 2 weeks after the first plasma RNA detection in all the placebo animals. This is a summary of the drug levels at the time of challenge. In the first column, the individual challenge. The second column is the plasma level of prodrug. The third column is the intracellular level of active drug. It's the MK8591 triphosphate, expresses picomole per 10 to the 6 cells. And in the last column, a conversion of the third column to micromolar. A couple of, to note here, first of all, that you can see quite clearly that the levels of prodrug in the plasma are orders of magnitude lower than the intracellular concentrations of drug, as shown in the last column. And you can see at the bottom that the mean concentration of active drug at the time of challenge approached the target of 1 picomole per 10 to the 6 cells. So in conclusion, MK8591 is a potent NRTTI that completely protects rhesus macaques against repeated low-dose intrarectal challenge with SHIV 109CP3 1 week after dosing. Intracellular active drug concentrations that afford protection are achieved at low dose levels in humans, and these results support the potential use of MK-8591 for HIV prophylaxis in individuals at high risk of acquiring HIV infection. I'd like to acknowledge my colleagues at the Aaron Diamond AIDS Research Center and our colleagues at Tulane National Primate Research Center who performed the animal experiments, and of course our colleagues at Merck who provide scientific support, compound, PK analyses, and most importantly of all, funding. Thank you for your attention, and I'm happy to take questions.
Thanks, Marty. This paper is now open for questions. So while I'm waiting for people to come to the microphone, just what's next then, Marty? Where do we go from here?
Well, obviously, the drug is being developed for both treatment and prevention. I personally don't have much to say about that, but I know Jay is in the audience. Jay, do you want to comment on what the plans are with the compound in the near future?
So, obviously, MK-8591 does exhibit the potential for prophylaxis. We are still exploring options in this space.
In this context, do you have any idea about rectal or vaginal concentration?
Well, there have been studies that show that the drug concentrates to substantial levels in both cervical and rectal tissue. And these levels are comparable to tenofovir diphosphate. But given the difference in potency, one would imagine that this may be an extremely potent agent. Yes.
Mark Boyd, Kirby Institute Australia. It's a great presentation, Marty.
Oh, thanks, Mark.
Can you just clarify? I mean, is this a new class of agent, given it's a translocation inhibitor?
So there are aspects of the compound that differentiated from nucleosides. I don't have a structure, but Sheena actually, I did send her the structure. There's a 3' hydroxyl group that is more like adenosine than other, like tenofovir or other drugs. So it has super high affinity, number one. And once it's in, it basically is very hard to come out. And as opposed to just chain terminating, what it does is basically stops the primer from ratcheting up from the recognition side to the nucleoside incorporation side. So indeed, it can be considered a new mechanism of action. And the other thing that's so important is that it's relatively resistant to excision, which is a very important mechanism of resistance. If you do in vitro passage experiments, M184V does come up, but the fold change is relatively low, and animals infected with M184V virus can be suppressed with the compound. So it's very, yeah.
So Marty, a last question just really for people to be able to sort of translate this. What sort of dosing if this became prevention or treatment?
So what I showed you today corresponds to a 10 milligram oral weekly dose. And this is based on treatment data. And what we don't know about this compound is how low you can go. And we are trying to do this in the animal model and try to understand what is the bottom concentration that will protect, and then that will translate into alternative delivery devices. Yeah.
Thank you.
Thank you.
Thank you very much. So our almost final, but not quite, penultimate abstract is from Joseph Aaron, the University of North Carolina at Chapel Hill, and he'll be telling us about the safety and efficacy of long-acting CAB and rilpivirine as two-drug IM maintenance therapy, also known as LATE-2, and these are the week 96 results. Thanks, Joe.
Great. Well, I'd like to thank the organizers for allowing me to present these data on behalf of my colleagues listed on this slide. Here are my disclosures. As a way of background, cabotegravir is an HIV integrase inhibitor that's similar to dolutegravir. It has an oral formulation and then an IM injectable formulation with a half-life between 20 and 40 days. Rilpivirine, you're probably very familiar with, is an HIV NNRTI, also with an oral form, and again, a long-acting nanoformulated injectable that has a half-life in 30 to 90-day range. The safety of this two-drug and the safety and activity of this two-drug regimen was had a proof of efficacy with oral therapy in the LATE study, which was published by David Margolis in Lancet Infectious Disease. And the LATE-2 data at 48 weeks supported the decision of moving these two long-acting injectables into phase 3 studies. The every 8-week dose was continued, and I'm going to show you results at 96-week for both 4-week and 8-week injectable compared to oral therapy. So the objectives were to establish proof of principle for this first ever long-acting injectable treatment. The primary objectives were, of course, safety and efficacy of the CAB and rilpivirine long-acting. Also, a goal was to select the dosing schedule for phase 3 studies. And key secondary objectives include pharmacokinetics and tolerability and acceptability. This is the study design. First began with an induction period. And this induction period enrolled individuals who were older than 18, were naive to therapy, had CD4s greater than 200. They couldn't be hepatitis B positive and had typical laboratory criteria. Those who were enrolled, there were 309, received cabotegravir and abacavir orally for 20 weeks. And over the final 4 weeks of that induction period, they received rilpivirine orally to demonstrate tolerance and build a level of rilpivirine. Those who qualified for the maintenance therapy had to have a viral load less than 50 copies between week -4 and day 1. At day 1, they were randomized to the maintenance phase, and everything I'm going to show you from here forward pertains to this maintenance phase. Individuals were randomized to either every 4-week long-acting CAB and cabotegravir and rilpivirine. Those are 2 ml injections, so 2 ml injections every 4 weeks. The second arm was every 8-week cabotegravir and rilpivirine intramuscularly, and those are 2 3 ml injections every 8 weeks, and then the third arm is continuation of oral therapy, and it was a 2 to 1 randomization with 286 individuals randomized. This is the population characteristics. The median age was 35, 8% women, 15% people of African American heritage, few CDC AIDS diagnoses. The viral load at entry to the induction phase was 4.4. 18% were above 100,000 copies, and the entry viral load was 489, entry CD4 489 cells. Here's the overall results. This is just to give you a snapshot. You can see all arms performed very well over the 96-week course of the study, and I'll show you a more detailed look at the 96-week results. So going left to right, 94% of participants on the Q8 week had a virologic success, compared to 87 on the Q4 week and 84 on the oral therapy. If we look at virologic non-response, so these are individuals who either left the study with a measurable viral load or had a measurable viral load in the 96-week interval for the snapshot analysis. And you can see there were 4% with the Q8 week. There were so virologic response was complete for every 4 week, and 2% or one participant on the oral therapy. No virologic data means the either the individual didn't show up during the 96-week window or had discontinued. And you can see there were some differences between the treatment arms, which I'll go into in detail. On the right-hand side of the slide gives you the point estimate comparing the injectable with the oral therapy. You can see that the point estimates favored both the every 8-week on top and the every 4-week on the bottom, though because it's a phase 2 study, the confidence intervals are relatively wide. So this goes into detail of the snapshot analysis. So if we follow the columns down, the Q8-week IM, you can see that 5 individuals met the criteria for non-response. 2 had viral loads in the window, and this was low-level viremia with 87 copies and 118 copies in those individuals. 1 discontinued for lack of efficacy, and 2 discontinued for other reasons, but when they left the study, their viral level was detectable. 2 patients had no data in the window. If you look at every 4-week, you can see that all patients that were available at that time met the criteria for virologic response. And I'll actually go into detail on the next slide of the 15 participants who had no virologic data and the data for the oral therapy. There was 1 patient who discontinued for lack of efficacy and 8 individuals that had no virologic data. Here are the data on the Q4-week arm who had no data in the window. There were 9 participants who stopped due to an adverse event, and you can see there's really no consistent adverse event. They're all actually separate entities. There were 5 participants who left for logistical reasons such as relocation, pregnancy, or medication that was required. And finally, there was 1 participant who didn't have data in the window, but subsequent viral loads were suppressed. This slide goes through protocol-defined virologic failure, which is essentially a confirmed viral load greater than 200 on study. In the Q8-week arm, there were 2 protocol-defined virologic failures, 1 without emergent resistance. This was in a participant who had, this occurred early, and there was actually no rilpivirine detected in patient samples, and there may have been a problem with the initial administration. And then there was 1 individual who had protocol-defined virologic failure with both integrase and NNRTI resistance at week 48. There were no protocol-defined virologic failures in the Q4-week arm and 1 in the oral CAB NRTI arm. Between week 48 and 96, there were no additional protocol-defined virologic failures. These are the adverse events. This is adverse events excluding injection site reactions. The top of the list are those adverse events that occurred in 3% or more of individuals, and you can see they're kind of typical adverse events that we see in clinical trials. If we look at grade 3, 4 adverse events excluding injection site reactions occurred in 13%, and those that were drug-related were only in 3%, again excluding injection site reactions. Serious AEs occurred in 10%, none were felt to be drug-related, and there were AEs that led to withdrawal in 10 of the participants out of 230 total. Grade 3, 4 labs occurred in 24%. Here, this slide gives you the injection site reactions over time, and you can, these are of any grade. It's important to note that 99% of the injection sites were either mild or moderate in severity and resolved within 7 days. You can see that initially 80 to 90% of individuals had an injection site reaction with the first injection, but that seemed to decline over time. Most of the events were actually pain. Nodules occurred in 8% of the events, and swelling and pruritus in 6%. And only 2 individuals discontinued due to injection site reactions, and note that both those discontinuations occurred in the first 8 weeks of the maintenance phase. These are the patient-reported outcomes, which gives you the satisfaction. On the left, it's asked participants how satisfied they were with current treatment, and The yellow is very satisfied, and 5 is highly satisfied, and you can see that the vast majority of the patients, the participants, were satisfied with their treatment. And then on the right-hand side is how satisfied would they be to continue, and again, the overwhelming number of participants were happy to continue their injectable therapy. So in conclusion, the data from LATTE 2 at 96 weeks show that cabotegravir long-acting with rilpivirine long-acting dosed every 4 or 8 weeks successfully maintained a viral load less than 50 copies. Two participants met protocol-defined virologic failure, as I mentioned, none after 48 weeks. The majority of injection site reactions were pain with a grade 1 or 2 with a median duration of 3 days. Only 2 individuals actually discontinued due to injection site reactions, and overall satisfaction of participants was high. As you know, every 4 weeks was selected for the 2 ongoing pivotal phase 3 trials, though now the 96-week data demonstrate durability of both every 4 and every 8 weeks, and the every 8-week dosing is being evaluated for an upcoming phase 3 study. The manuscript detailing these results was published today in The Lancet and will be available to you online. Finally, I'd like to acknowledge everyone who contributed to this, especially the participants and their families and the investigators that are listed on the slide. The study was funded by Vive Healthcare and Janssen, and the study team in particular would like to express our condolences to the family, friends, and patients of Dr. Lewis Sloan. He's the co-author. He is a co-author of the paper, but he unfortunately died towards the end of the study, and we regret his passing. Thank you very much.
So this paper is open to any questions. So Joe, while perhaps others are gathering, I'm quite surprised that the acceptability was the same for the 4-week and the 8-week. I would have thought 6 doses, would be a lot more attractive. I mean, what are just your thoughts about, would we finally offer sort of differences to people? Or
I think that the fact that now with longer data, it looks like the every 8-week and the every 4 are very comparable. I don't think we can say one is better than the other in terms of activity. I think that given a choice, people would prefer probably 6 injections a year versus 12. And I think the way the questions were asked, it was really about kind of tolerability, acceptability of the therapy, not so much of the interval. So I think that's a question that could be asked in the study, the phase 3 study that's under design. Great. Thank you.
I have a question. It's kind of along these lines. So your patients are very satisfied with this treatment. Every 8 weeks sounds great. Do you also have an analysis of what kind of people are the people that are very satisfied with this product? So it's like on forehand to select the group of people that would be most willing to use this product?
Yeah, I think that's a question really for all of us to answer. In this particular study, we had mostly men. They were younger, that median age was 35, and there were people that knew they were signing up for a study of an injectable therapy. So I think how this will go and when it hopefully gets rolled out and approved, I think is an excellent question. I suspect there are many HIV-infected individuals that would prefer not to be on pills. This does have to be administered in a healthcare setting right now. It is not self-administered. They are IM injections. So I think that will define, in part, who will be using this medication. But I think it's really for all of us to kind of figure out who will be the best people for this therapy.
One small one, also along these lines. So we see this new medication hit the market, but they're not always accessible for everyone. How do you see your role in that, for example, with this product?
As a clinician and an investigator, I think my role is an advocate for my patients to make these drugs accessible. I don't have any control on how the drug is exactly developed, but obviously we want this therapy to be as accessible as possible.
So unless it's very short, we're just out of time, so can you just keep it quite short? Yeah.
Among those people who had adverse effects, how was it handled, and how long did the adverse effects last for in the long-acting arm?
It was almost always a pain, and almost all the pain resolved by 7 days. There really is no really specific thing except for you want to avoid vigorous activity, and you want to avoid you want to not be completely inactive. But again, that's something we're still working out. But it was mostly pain, it was mostly short-lived, and mostly mild.
The last abstract is not on HIV, but on the first results of a new drug, DEA, on hepatitis C in West Africa. The presenter is Karine Lacombe, professor of infectious disease in Saint-Antoine Hospital in Paris, and for the treatment of chronic Hep C of patients with or without HIV in West Africa, the TACA-NRS trial.
Thank you. So, on behalf of my colleagues from Cameroon, Côte d'Ivoire, Senegal, and France, I'm very happy to present you the interim result of the TAC trial, treatment for chronic hepatitis genotype 1, 2, and 4 in patients with or without HIV and living in Central and West Africa. Those are my conflict of interest, and I would like to highlight the fact that Gilead gave the drugs for the trials but did not participate in the analysis or interpretation of the data, and NRS sponsored this trial. So a few key messages from background. So for the past years, we've been experiencing a change in the paradigm of HCV treatment thanks to the efficacy and tolerability of direct antiviral agents against hepatitis C. And WHO has committed to reach 90% of those infected to be diagnosed, 80% of those diagnosed to be started on treatment, 90% of those on treatment to be cured, for a 65% decrease in liver-associated mortality by 2030. So it's realistic to think that we're going to reach a global hepatitis C elimination. However, the reality in sub-Saharan Africa is different. There is a high health burden associated to chronic hepatitis, including hepatitis C. In most of the countries, there are no national hepatitis plans, there are no universal screening policies, and usual tools for screening for hepatitis are not adapted to resource-limited settings. And finally, in most of the country, there is no access to DIAs, and in those where treatment is available, only the private sector provides treatment. In this context, we have designed a TAC research project around the clinical trial, for which I will present you the interim results today. But there are many aspects in this research project. One of the study is on diagnostic strategies. There is a socio-behavioral study, a study on morbidities, and a cost-efficacy analysis as well. So the objective of the TAC trial, main objective was to evaluate the efficacy, sustained virological response 12 weeks after end of treatment of a 12-week course of interferon-free regimen containing sofosbuvir plus weight-based riba for genotype 2, sofosbuvir and ledipasvir for genotype 1 and 4 in treatment-naive patients infected with hepatitis C genotype 1, 2, and 4. So you see that HIV was not an exclusion criterion. Secondary objective with the clinical and biochemical tolerability and safety, the on-treatment HCV kinetics and its determinants, and the sustained virological response 24 weeks after end of treatment. There are two secondary objectives that are really important in the context of sub-Saharan Africa, was to provide a capacity building in virology and use of elastometry, and finally to build a network of clinicians, biologists, patients associations, and stakeholders in order to improve knowledge in the field of hepatitis C and grant larger access to HCV drugs. So that's a real advocacy objective. The main eligibility criteria are described here. The inclusion criteria confirm GT1, 2, and 4 hepatitis C infection, a plasma HCV RNA detectable, no history of HCV treatment of any kind, birth control method, especially for female patients on ribavirin, and in case of HIV infection, has to be confirmed, stable HIV treatment for at least 8 weeks, and the current CD4 count above 100, and the current plasma HIV RNA below 200 copies. The non-inclusion criteria were a co-infection with hepatitis B, the cirrhosis, child pug B or C, so decompensated cirrhosis, and in case of HIV infection, a recent severe opportunistic infection or a bad expected adherence. Here is a study design. So we have included 80 patients, genotype 1 and 4, 40 genotype 2. They've been on treatment for 12 weeks, and then we have analyzed the primary endpoint, the sustained virological response 12 weeks after end of treatment. Regarding the number of patients in each group, we included 40 patients in each group, genotype group, and we are here presenting the preliminary results on the 110 patients, over 120 who have been included, and the study is still ongoing. Here are the baseline characteristics of the patients included. So you see first 33 genotype 1, 40 genotype 2, 37 genotype 4, who are presented here, so an overall of 110. Just wanted to highlight the fact that about 29% of those patients were HIV infected, and regarding cirrhosis, about between 10 and 20, depends which surrogate marker you take. Now, a highlight on HIV patients. So you see that those patients were very mildly immunocompromised, and all of them were, almost all of them had a HIV viral load below 50, and all of them were under 200. You see that the first line is the most common line, the first line ARV therapy, the most common line used in Africa. Now the results, sustained virological response 12 weeks after end of treatment. At present time, for 110 patients, we had 89.1% of SVR12. And you see that the results are slightly worse in patients with cirrhosis, but there is absolutely no influence of HIV status. Regarding now the safety and tolerability, we looked at the evolution of hemoglobin and ALT. So you see, you can see that the rate of ALT went down under treatment and then stabilized, and the patients who experienced relapse, so failure, had an increase in ALT at week 24. Regarding hemoglobin in genotype 2 patients who were treated with ribavirin, the tolerability was quite good. We had a decrease as expected under treatment, but then it stabilized quite quickly and remained at the same, and went up again at the same level pre-treatment and after treatment. So 4 patients had a hemoglobin decrease under 10 milligrams, sorry, and 2 had a subsequent riba reduction. We had no loss of follow-up. 1 patient had an early discontinuation at week 8 due to personal reasons. She traveled abroad to Gambia, but then went back, and he was in fact cured. 5 events occurred or aggravated between inclusion and week 24, and we are validating the events right now. And we had 2 cases of arterial hypertension that did not exist before introduction of treatment. Regarding now adherence, medical intake ratio at week 12, that was based on pill count. So you can see that it was really good for genotype 2 regarding sofosbuvir and riba, very good for sofosbuvir and dipasvir in genotype 1, and slightly lower for genotype 2. And we are right now investigating the reasons, the determinants of this decreased adherence in genotype 4 patients. Now, some data regarding the resistance genotyping in failing patients. So you see here the evolution of HCV RNA viral load, the HCV kinetics. So you see a rebound of the HCV RNA in failing patients. And we have started to genotype the patients who failed. So you can see here the result of 4 patients according to genotype. So one patient could not be amplified, one viral strain of a patient could not be amplified on the NS5A region, and one was amplified and expressed 2 known, very well-known resistance to NS5A components like ledipasvir. And one patient who was treated with sofosbuvir and riba had resistance to tenofovir, which confers a decreased sensibility, not a real resistance, but decreased sensibility to sofosbuvir, but usually those mutations disappear quite quickly. So to conclude, the trial is still ongoing. We have 2 patients waiting SVR12 in August 2017, so we are on the verge of completing the trials. We have the result for 8 more patients, but they are not shown here because they have not been monitored yet. The interim SVR12 is close to what is reported globally with the same DIAs, with excellent tolerability and no safety issues so far. You saw that there was no impact of HIV on efficacy, safety, and adherence of treatment. And as expected, there was a suboptimal efficacy in cirrhotic naive patients. So I think that now it is time to scale up HCV screening and advocate for treatment access for those in need in resource-limited countries to make the global HCV elimination a reality for all. And I would like to acknowledge my colleagues from the 3 countries, from France, Scientific Committee, the DSMB, and INRS, who sponsored the trial. Thank you.
Thank you, Karine. Great result for plaidoyer for access to drugs. We have time for 2 questions. Just a question. What will be the next step? You speak about the program and not only the trial, but what will be the next step?
Okay, so the next step will be to focus on screening and develop simplified screening strategies. I think it's one of the most important research gaps in resource-limited settings. What tools would be cost-effective in resource-limited settings. And then we probably have to focus on key populations in those countries. You know, the prevalence of hepatitis C is different between all the countries, and we know that in some countries it's really associated to healthcare procedures a long time ago, but now there is a thriving hepatitis C epidemics in key populations such as drug users, either in Western Africa or Eastern Africa. And that's the other very important key element to tackle the hepatitis C epidemics in Africa.
Question?
Thank you so much and congratulations. I'm wondering how quickly the trial enrolled and if there was a plan for people who wanted to enroll but weren't able to because it was full.
No, not really. Well, in fact, you know, that's why I think that the screening is really important. We enrolled quite fast, but you know, almost nobody is screened. So at the same time that we were enrolling patients, we had to implement screening campaigns, and that really highlights the need for universal screening for hepatitis.
Great. So thank you very much, Karine. And thanks to all of you and to all the speakers for this multidisciplinary sample. It was a choice of the co-chair.